we did talk about the Endeavour trial. I want to move on there. At this meeting, last year and then 2 trials at this meeting have done triplet therapy with lenalidomide dexamethasone as the backbone, and either carfilzomib in the Aspire clinical trial, Elotuzumab in the Eloquent trial, or Ixazomib in the Tourmaline trial. And we have the principal investigators of all these trials here, I think, so we should be able to cover this pretty well. Let's talk about those, just quick snapshot of all of them, and then when would you use one and when would you use another? So let's start with, we'll come back to Aspire. Let's start with the Eloquent clinical trial because AJ mentioned that already.
So Eloquent 2 was a randomized trial of elotuzumab plus Lendex versus lenalidomide and dexamethasone in a 1 to 3 prior lines of therapy patient population. What we know about Eloquent 2, as reported at ASCO this year, is that the progression-free survival was about 30% better than what you'd see with lenalidomide and dexamethasone, and that about a third of the patients in that trial met what we would, through the IMWG, consider to be high-risk disease by genetics. And genetics in this trial was done centrally. What I think, sort of from my perspective, are the take-home messages from that trial are that in the subgroups of 17p and 414 translocation, there was a significant benefit for the addition of elotuzumab over Lendex alone, and that for response, equal response, PR versus PR, if you got Elo, the durability of the PR was longer than if you didn't get Elo, and the same for VGPR or better. And that actually has not been shown in a randomized trial before.
Right. Excellent point.
So Eloquent, elotuzumab added to RD, clearly an advance, improvement in progression-free survival, prudent time to progression.
Yes.
We're waiting for some survival data.
Yeah, but there is a trend, and the important point, I would echo Sagar's points. The other thing is it's a very well-tolerated antibody, and it has a very convenient infusion schedule, which I think for practicing oncologists is a very relevant point.
How long is the infusion for elotuzumab? I haven't used it a lot.
So there's the first few doses are probably around 3 to 5 hours, somewhere in that ballpark, but there is an accelerated 60 to 90 minute infusion as well, once you get past the first few doses.
So to be precise, you've got basically, Sagar's quite correct, it's about 3 hours to kick off with, and then you can taper right down, and basically there is, once you're beyond cycle 4, you can be at about an hour and a half,
and we'll
which is very
we'll probably come back to the infusions in a minute. Ixazomib, Tourmaline trial.
Well, this is again, it's been an incredible year in our world, I think. And I think the Ixazomib data, which will be presented by my colleague Philippe Moreau at the meeting, is really remarkable. It's showing a 6-month progression-free survival benefit in favor of the 3 drugs versus the 2. And I think the thing that's very interesting is a couple of things, really. One, the tolerability of this approach has been excellent. There's obviously too early for maturity in terms of survival benefit. But to a point that Sagar made, the high-risk population are really being well addressed with this platform. And again, the 17p deletion subpopulations stand out just as they did in Eloquent 2. And I think that's very favorable. One interesting thing about the Tourmaline data is that the progression-free survival curves, whilst there's a response rate difference and all those things, they don't separate very early. It takes up to 9 months before they separate. And I honestly believe that one of the reasons for that, I think there are a number of factors to the way the trial was done. It's a very real-world population. We allowed refractory patients, primary refractory patients into the group. So this confounds us a little bit. But I also wonder whether the once-a-week schedule of Ixazomib is one of the issues here in terms of the rapidity of progression-free survival difference. Having said that, we're very pleased with the combination approach. It's clearly been very favorable.
You may have said this at the beginning, but this is an oral proteasome inhibitor.
Absolutely,
with
once a week. Exactly, absolutely once a week. Yeah.
The Aspire clinical trial, which is a trial that I was part of, took lenalidomide dexamethasone as well and combined it with carfilzomib at the labeled doses of 20 to 27 milligrams per meter squared. In that trial, the progression-free survival was quite long at 26 months, but interestingly enough, the lenalidomide arm of the trial also did a bit better than the other 2 studies. However, what was impressive about the carfilzomib lenalidomide dexamethasone regimen was the depth of response was very high, but 1/3 of patients entered a stringent complete remission with this therapy. And I think some of us were concerned that by adding a third drug, we might see a significant increase in toxicity. And in fact, that proved not to be the case, except in this, as we've all discussed already, a very small percentage of patients who had some symptoms compatible with congestive heart failure, increase in hypertension.